Hi, my name's Laura. I'm very happy to be here today. To have the opportunity to talk about my research that I did in Sierra Leone as part of my master's degree in international community health here at the University of Oslo. So just briefly, outline of what I'll cover in the next 15 minutes. A brief background to maternal health, specifically in Sierra Leone, the objectives of my particular study, the methods I used, the findings, and then a bit on the conclusion. And then I thought it'd be good to discuss a little bit about recent events, particularly in Sierra Leone and West Africa. I thought I would start with a story from one of my participants. These were the words spoken to me by a 16-year-old girl in one of the villages that I was at. She says, "I really want the old woman to take me to the hospital to deliver. But when the other people told me to stay here and wait for a time, that is why I stay. I don't have any understanding about delivering. They're the ones that have the experience. So anything that they tell me, I need to listen to them." So this was a 16-year-old. She was describing her first pregnancy and her first labor. She gave birth in the village of where her parents were from. She had left her husband to be closer back with her parents and her family. She went into labor late on the Saturday night. About a day went by. She got worried. She wanted to go to the hospital, but she was advised to wait. There was no need. She had to stay in the village. The TBA who was assisting her advised her family to go and find an old granddad from a village nearby. He had experience in childbirth and was to come and assess her. He did. He gave her some tablets. In the meantime, her uncle, who was waiting outside, got worried and tried to find a motorbike so they could take her to the hospital. The time went on. Eventually, on the Monday night, she gave birth. This was before the uncle was able to find a motorbike for them to be able to go to the hospital, even if they wanted to. This was a lucky outcome. Her child survived, but unfortunately died within the next 6 months. So a little bit about Sierra Leone. It's on the west coast of Africa, between Guinea and Liberia. It was previously well known for the 11-year civil war that ended in 2002, but more recently it's well known because of the Ebola epidemic that's been going on. I believe it's 183 out of 187 on the Human Development Index. Life expectancy at birth for both men and women is less than 50 years. And the majority of the population rely on subsistence farming. So, maternal mortality. We know that globally it has been improving. It's not all bad news. However, within sub-Saharan Africa, it's still a big problem. So the maternal mortality ratio globally is 209 per 100,000 live births. And in Sierra Leone, before I did my research, it was 622. I think we can confidently say it's a lot worse than that now. Internationally, it's been agreed upon that if you increase the number of women given birth with a skilled attendant, it should reduce the maternal mortality. This is the case within Sierra Leone, where the government have been trying to encourage women to give birth with a skilled attendant, and this usually means it goes hand in hand with giving birth within a health facility. In 2010, the government within Sierra Leone introduced the Free Healthcare Initiative for pregnant women, lactating mothers, and children under 5. This was because they found that the cost of healthcare was too much, and that put so many women off giving birth within the health facilities. In addition to this, there were informal bylaws that were introduced across the whole country. They were usually enforced by the local village chief, so that if a woman gave birth at home, her or her husband or the TBA who assisted her would be fined. So initially, after the introduction of this free healthcare, the percentage of women given birth within health facilities did increase. It increased up to 54%. But then by 2013, so 3 years later, it only increased to 54.4%. And it was also found there was big discrepancies between women that lived rurally and women that lived in the urban setting. So this is where my research came into place. What we found in the literature was that there was limited knowledge around how women and their communities make the decisions during childbirth, how they make the decisions to either stay at home or to go to a health facility, who they want to be helping them. So I looked at these decision-making processes that were made by the women and their communities, exploring the potential risks that they perceived and who and what influenced the decision-making processes. In addition, I was also looking at the influence of the free healthcare and the bylaws. So I was in Sierra Leone from August to December 2013. I was in the northern province of, in Tonkalili district, Lelenken section. And I did my research in 2 remote villages in that section. The methods that I employed were focus group discussions, group and individual in-depth interviews, as well as informal interviews with NGOs such as Mary Stopes and like the local radio station to see what topics they discussed. The people that I interviewed were women who'd been pregnant within the last year, older women who had been involved in a pregnancy and a birth within the last year, and men who had a close family member who had recently given birth. I also included the TBAs, health workers, and then also a group of moto boys, as they're called locally, who are the men who ride the motorbikes around from the villages, and if a woman was to get to the hospital, that would be the way she'd get there. So my findings. In these 15 minutes, obviously I don't have time to go through all of the findings, but I thought I'd draw out some interesting bits. For the majority of my participants, home delivery was seen as the norm. A safe and normal delivery was one that occurred in the home, in the village. People only went to the hospital if there was a problem. You didn't usually go preventatively. However, this wasn't the case for all the women. Some women actually wanted to go to the hospital preventatively. They wanted to go there just in case there was a problem. However, they may not have been able to actually get there, and a number of, say, like structural factors came into this. Despite the fact that there was the free healthcare, and nearly everyone I spoke to was aware of this free healthcare, they all spoke to me about the need to give like a thank you payment. A way of showing appreciation. So although this wasn't described as a bribe, it wasn't actually seen as payment, it was still seen as something you had to have. And you wouldn't go to the hospital unless you had money. And then on top of this, there was the transport issues, other things that would be putting these women off. With regards to risk, for example, this would also dictate who they wanted to help them or where they wanted to be when they gave birth. A number of women described to me the link between immoral behavior and an obstructed birth. So it was believed that if their labor wouldn't progress and they weren't able to give birth, it was probably because they had committed adultery during their pregnancy. So the way for them to be able to progress with their labor was to confess to the adultery. So there was no point going to the hospital. Why would you go there? Because if actually the problem is the fact that you haven't confessed to this adultery. So, in conclusion, the decision-making process that we found in rural Sierra Leone is very intricate and a dynamic process. It's usually an amalgamation of all the different past experiences, the perceived risks, and the social expectations, so what the women believe and also what the community around them believe. The decisions actually may be pragmatic, they may be rational, and they're often made within the constraints of poverty and other social determinants of health. And the final decisions, actually, they might be governed by unexpected circumstances. So, for example, there might be a woman who believes in the power of witchcraft, so therefore she does not want to go to the hospital. She doesn't want the people around her to know that she's in the vulnerable state of giving birth. If she goes to the hospital, they know that she's in this situation. She's more likely to have witchcraft done on her. So therefore, she will actively choose to give birth at home. However, maybe if something else comes up, such as bleeding, which was something that many of the women I spoke to saw as a serious problem that ought to be treated within the hospital, they might then change their minds and try and get to the hospital. But if it was rainy season and the rivers were flooded and she would have to wade up to her neck to get to the hospital, then actually, even though she might want to get there, the reality was that she couldn't. There are a number of recommendations that came out from our research. Future initiatives, they obviously need to have a clear understanding of the women's preferences, their beliefs, their perceptions of risks, as well as an understanding in the constraints in which they live. Another recommendation that we had was that the participation of all that are involved in the decision-making process need to be involved in these planning for future initiatives. So, for example, in rural Sierra Leone, childbirth is seen as women's business. It's not for men. However, the men often have the control over assets, control over finances. So if they're not part of this discussion, they don't perhaps always understand the importance of the woman being able to have the money so that she is able to go to the hospital, so that she can pay for the transport and to pay for this fee, whether this fee should be there or not. So I thought we should also discuss a little bit today about the recent events within West Africa and Sierra Leone. So as I'm sure everyone here knows, in December 2013, Ebola first occurred in Guinea, and then it spread to Sierra Leone in May 2014. I believe there's been perhaps over 23,000 people infected, and I think the latest stats are over 10,000 deaths. This isn't clear, it's probably more than this. There have been, like UN sources have shown that there's been a higher proportion of women being infected and dying from Ebola. There's a number of reasons for this. The traditional roles that women particularly hold, say within their household, where they will be caring for the sick people, so they're more likely to catch it. Pregnant women in particular, they have an increased vulnerability to the virus. There's been research or discussions that perhaps as a pregnant woman's immunity lowers, maybe she's more likely to get it and less able to fight off the virus. There's also been discussions around perhaps there's a lower priority for pregnant women to have to be treated for the Ebola. It's quite known from previous Ebola outbreaks that pregnant women have less of a chance of surviving. So therefore, if you have someone who you think is more likely to survive this virus, perhaps you're better off giving all of your resources and all of the care that you can to that person rather than the pregnant woman. But what this means is then the pregnant woman gets no care, and she is, of course, even more likely to die. So therefore, it's a vicious circle of meaning that pregnant women are even less likely to survive the virus. The research that has been done so far that I've been able to find, there was a study in Sierra Leone that showed that there's been a decline in inpatient admissions and major surgeries. So this will be including cesarean sections. So as we know, that means any woman that's been needing an emergency treatment for her labour won't have been receiving it and most likely will have died. And I read recently that they estimate that the maternal mortality ratio within Sierra Leone has probably gone back up to 2,000 per 100,000 live births, which is the same as it was during the Civil War. So what has been gained in the last 10 plus years since the Civil War has probably been lost with regards to maternal health. If I link this back to the research that I was doing and the findings that we had, the accessibility of the health services will be even harder for the women now. There's been a huge strain on an already very weak health system. There's much less health workers. Many of them have actually died during this epidemic. Being able to get to the health centres has been difficult due to the quarantine, the roadblocks, as well as many of the health facilities being closed. And also there's been reports of women being turned away from the health facilities. There were reports in Liberia about doctors charging extravagant amounts to assist a woman during her labour. So there's potential that that's also been occurring in Sierra Leone. Perceptions of risk will be something else that's probably been affected. So I think CDC did a study last year in Sierra Leone, and they found that there was fear of the women in accessing the health services. They were fearful of contracting Ebola from their health workers. They were fearful of catching it from the other patients. They were also scared to be diagnosed with Ebola and then to have the stigma that's associated with it, to have their whole family put into quarantine. And equally, there was fear on the side of the health workers. Labour is messy business. There's a lot of bodily fluid involved. The chance of catching the Ebola virus from a pregnant woman who's hemorrhaging very badly is much, much higher. However, it should be noted that there isn't that much research at the moment about what's been going on within these three countries. I think it's safe to say that the maternal health there has been affected severely and will be needing a lot more support in the future. Okay, thank you very much for your attention.
Yes, thank you, Laura, for a very interesting presentation. Are there any questions or clarification? Or other questions for Laura?
There's one here.
Oh, there you go. Perfect.
Thank you for your presentation. Just a quick question. Did you have any, regarding to the decision making, did you have any, hear anything from them regarding either the perceived quality of care in the facilities or the experience of care within these facilities that affected their decision maker either for a subsequent birth or to the experience of others?
I didn't quite hear that, so we're going...
Oh, sorry.
No, that's all right. Do I need to put this back on? Yeah.
Did you hear me or not? I didn't.
Yeah, I think so. Can you just check that I've understood you?
Well, just if you heard anything related to quality of care that
Ah.
influenced the decision making of women.
Yes,
So.
yes, very much so. Thank you for that question. Yep, a number of women, they spoke to me about either being treated poorly by health workers within the health facilities, and that would affect them because often they would describe the traditional birth attendants as being kinder to them and not shouting at them. Particularly women that had a number of children, it was seen that if you'd had a number of children, you should know what's happening, and they were often told, stop crying out, stop causing us trouble, because you've given birth before, you should know what's happening. Yeah, so definitely an element of disrespect from the health workers. And I think a few things where, like, some women, they said they really wanted their mothers to be with them and they weren't allowed to. They were shut out. That was, yeah, another problem. And I think related to that in some way was the fact that in the hospital where I was at, for women to be able to give birth in the health facility, they had to have someone admitted with them to care for them. And that was also another hindrance because it meant that that person also couldn't be working in the fields, that person couldn't be looking after their own children. Yeah. Thank you. Did that answer you?